It's a pleasure to introduce you. The first speaker is Claudia Gomes Padilla from Brazil. There she is. The talk will be transdermal testosterone pretreatment, increase the number of oocytes and blastocyst formation in women with diminished ovarian reserve. You have 7 minutes for the presentation and 3 minutes for discussion.
Okay, thank you. Good morning, everyone. It's a pleasure for me to be here today, and I would like to thank the opportunity to share with you some of our experiences on transdermal testosterone supplementation for women with pure ovarian reserve, a self-controlled comparison at this study. So, androgens could be an add-on therapy to improve ovarian response, as suggested by animal models. It plays an important role in folliculogenesis due to a better prenatal activity, mainly by increasing FSH receptors and stimulation oocyte maturation. Androgens can take place early in the follicle recruitment and selection. It takes place at the primary stage at the follicle, but mainly at the secondary and small antral stage follicles, stimulating granulosa cells maturation in synergy with FSH. So, based on these animal studies, clinicians started to use testosterone supplementation in order to get a better ovulation induction response for IVF patients, mainly improved responder patients. So here you can see some of the randomized control trials about this team. And although some of these trials shows a better IVF outcomes with testosterone supplementation, this issue is still controversial in medical literature. So in this way, our objective was to assess a possible beneficial effect of transdermal testosterone supplementation in women with diminished ovarian reserve and previous in vitro fertilization failure. This was a retrospective study with humans submitted to IVF-ICSI-PGS treatments between January 2016 and December 2017. Our inclusion criteria was women with diminished ovarian reserve, defined as antral follicle count lower than 7, and/or an antimillerian count equal or less than 1 nanogram per ml. And our exclusion criteria was when a spermagogue had a sperm concentration below 5 million sperm per ml, a diagnosis of a stage 3 or 4 endometriosis, and whenever a couple has any karyotype anomaly. It was a self-controlled study, so all patients had 2 GnRH antagonist cycles. The first one was named the control cycle, without any testosterone pretreatment, and the second one was named testosterone cycle, when transdermal testosterone was given in a dose of 10 to 25 milligrams daily during 30 to 60 days before treatment. And the posology of transdermal testosterone was chosen according to medical preference. So, as expected, the age and the results for ovarian reserve evaluation was similar between the 2 cycles, as it was for the total dose of gonadotropin used. Here, you can see some of the IVF outcome results. And for the number of oocytes retrieved, the number of M2 oocytes, cleaved embryos, the number of blastocysts on day 5, and the top quality blastocysts on day 5, we had better results when testosterone supplementation was used. And cycles considered due to low ovarian reserve was lower when testosterone cycle was used, and the number of euploid embryos did not differ between the two cycles. So based on these results, we can conclude that testosterone may have a beneficial effect in patients with decreased ovarian reserve. And we had a high number of mature oocytes, blastocyst formation, and top morphology blastocysts when testosterone was used if compared with the same patient to her previous cycle. The number of euploid embryos available for transfer was similar between groups, possible due to advantage patient's age studied here. The interpretation of data has limitations as for every retrospective study. However, the self-control method could be a good model to enhance the power of the data analyzed retrospectively. And besides, testosterone may have a benefit in these patients. Of course, a high number of patients is necessary to evaluate the effect of testosterone pretreatment in pregnancy rates. Thank you for your attention.
And
Thank
the
you.
paper is open for discussion.
I have a question. Can you tell us something about if you note some side effect in the patients or some compliance in the patient that use the testosterone?
Yes, sometimes we had some side effects, but it was quite a few, and it was not harmful for the patient, and the majority of them really, in fact, like it.
Thank you.
Thank you. The next presentation is Dr. Birgit Ausberg from Denmark. Serum progesterone levels determine the reproductive outcome of hormone replacement therapy in frozen towel embryo transfer cycles, a cohort study of 244 cycles.
Okay, thank you for the introduction, and thank you for the opportunity to give this talk. It's always nice to talk about your favorite topic. The background of this topic is that a few years ago, I visited one of the old IVF pioneers from Australia, John Jovitz. He has this hypothesis that serum progesterone levels matters, and he has a very persuasive way. So what he did, he has very nice results in his HIT. So he presented in 2019, and what he showed was there was the best pregnancy rate or even live birth rate was when you had a serum level between 70 and 100 nanomole per liter. It was quite a huge cohort, and it was all vitrified blastocysts. It was single embryo transfer. To have these very high serum level, he has in-house produced progesterone pessaries, and it was 400 milligram progesterone, and it was administered 3 times. When I came home to Denmark, I thought, how can we increase our serum progesterone in our patients? And what we did, before we gave progesterone vaginal gel, 90 milligrams 2 times a day, that was the standard, and then we increased it for 3 times a day. And this is the retrospective analysis of the cohort. It was 244. They had all HIT cycles, of course. They had all blastocysts vitrified, and it was on day 5 and 6. And of course, we had available serum progesterone, and we were measuring along with the pregnancy test. So no additional progesterone was given in this cohort. And this is the results. We found a cutoff of 35 nanomole per liter, and it was based on a sensitivity analysis based on different progesterone levels and its association to the ongoing pregnancy rate. And this is the result. We didn't find any difference in number of, actually there was much equal number in the high and the low group. It was 51% in the low group, and there was no difference in regarding age or body mass index or how many embryo we transferred or the age of the transfer. And the reproductive outcome, we saw a non-significant difference in the pregnancy rate and a non-significant difference in the early pregnancy loss, defined as a pregnancy loss before week 7. However, we found a significant difference in ongoing pregnancy rate week 12, 38 in the low progesterone and 51 in the high. We did a logistic regression analysis, and we adjusted for maternal age, body mass index, smoking, number of embryo transferred, and the age of the embryo transferred. And what we found was a significant decrease in the group of patients with a low progesterone, and it was significant, the risk difference in 14%. Are we the first to show this? No, actually last year, 2017, EBART and her group found the exact same cutoff for HIT patient. It was another cohort. It was oocyte donation cycles. It was fresh and frozen. And they were using another progesterone administration. It was 400 milligram micronized progesterone 2 times a day. What we did was we tried to increase the number of administration of the vaginal progesterone, and it doesn't seem to matter. We have, in our group, earlier showed that from administering this cranone, of course, we use, from 1 to 2, we increased live birth from 9% to 20%. At that time, we only used cleavage embryos, and it was slow freeze. That's why the low live birth rate. But increasing it further from 2 to 3, it doesn't seem to increase the serum levels. When we measure the average of this cohort, it's more or less the same as the one reported by the company when we looked at these averages. However, what we found was a very large individual variation from 0.3 to 110 nanomole per liter. So we should individualize the luteal phase support. Remember, half of the patients with this regime, they were perhaps undertreated. And of course, we need more studies. A lot of you coming from large clinic with a lot of HIC cycles, and I really think you should go home and make some of these RCT, because we are not there yet. The cutoff of 35, it's of course not the whole truth, but it's perhaps the best estimate for future studies embarking the progesterone supplementation in HIT. And especially with this lectures this morning, we know euploid embryos, we put them back, a lot of cost. So I think we own the patient to put it back in the best environment. So please go home and make the RCT we need. And this is my dear colleagues from the Public Fertility Clinic in Denmark. We're doing the best we can in more than one aspect. Thank you.
Any question from the audience?
I have a question.
There must be, yeah.
And how do you individualize this supplementation to?
Yeah, you saw this is quite new data. So what we have been doing from the last couple of months is that when we see these results, the next treatment we will supplement with the intramuscular progesterone. However, it's not very patient-friendly, but these patients will do whatever it takes. We are thinking about doing some rectal, perhaps, because I think we could increase the serum levels. But when we start administer the progesterone in a different way, not just vaginal, it would have other thresholds, I guess. But this is a new area, and we thought we'd just give them some progesterone and then we are home free, but I don't think so. And perhaps some subgroups of patients need more progesterone. What about the one with the big BMI or vaginal bacteria, whatever? We don't know much about. So one size fits all, no, I don't think so.
We have another question from the audience.
Yeah.
When do you measure progesterone?
At this study, we did it along with the pregnancy test. And of course, if I should do this again, I would do it on the day 5. Perhaps we could measure it before we thaw the embryo to see, is this a good cycle, or should we start doing mock cycles? Because the steady state from vaginal progesterone, it will be about 5 days in some products, and some products have a quicker steady state about day 2 or 3.
And regarding timing from administration of progesterone?
It was 1 to 3 hours. Yeah.
Thank you.
Yeah. But when you have the vaginal, there's not a lot of fluctuations. So.